to Behind the Plinth. Today we have got Maddison Law, exercise physiologist, and Lachlan Knuth, physio, on the plinth today. Today's question on Behind the Plinth for our physio and ex-phys to chat about will be how do we rehab from a stroke, and they'll run us through what a stroke is, how to rehab, and what their professions can do to help improve. I'm going to hand it over to Lachlan to start with.
Awesome, thanks Britt, and hello Mads, good to see you. Let's get straight into it. So stroke rehab is something that we do see regularly in the physiotherapy and exercise physiology realm, especially in our clinic recently. We can do it multiple ways. We can have people come in who have had a stroke and do our rehab in the rooms and in the gym. We can also go actually and do home visits as well if it's too hard for the person to actually come in here. So
yeah. And in the pool as well is another alternative.
Yeah,
so hydrotherapy at the local pool, which is fantastic. We also get good results from there.
Absolutely.
As well.
Yeah. So what is a stroke? So it's the blood supply to the brain is interrupted, and then can cause some serious side effects such as weakness on one side of the body, numbness, pins and needles, and obviously slurred speech and a drooped face. And any other signs to look for, Mads, on your end? That pretty much covers it.
Yeah.
Yep. So very serious thing to occur if involved with someone that is having a stroke and you see those signs. It's very important that you call 000, okay, and get them to the ambulance as quick as possible. Time is of the essence when dealing with a stroke.
Yeah, well, they like to say time is brain. So the longer they're impacted without having any treatment from medical officers, it's just more brain deterioration, damage, and potentially it can be fatal at the end of the day. So you'd rather call and make the mistake of being overcautious than not calling and umming and ahhing, and that's brain tissue gone.
Yep, absolutely. And Maddie will go into like the different type of strokes that occur. There are different types that affect different parts of the brain, which then of course obviously affect the rehabilitation process as well afterwards. Alrighty, Matt. So tell us what kinds of strokes are possible to occur in the brain. Can you just run down there?
So we've got at least two types of stroke categories that we look at, ischemic and hemorrhagic. So ischemic is where the blood vessel within the brain becomes blocked, depriving the brain from oxygen and the nutrients, leading to that damage that we spoke about just before. So typically you can have a blood clot that escapes from the heart or potentially comes on up into the brain and done from there. Yeah, other one is hemorrhagic. So think about hemorrhaging, you got bleeding. So it's a blood vessel within the brain that's ruptured, causing the blood to obviously go where it's not meant to be, creating that more damage, just as we said before. Now, to be classified as a hemorrhagic or ischemic, the symptoms after the stroke occur or the accident need to last for at least 24 hours. Now, if the symptoms do resolve within under 24 hours, it is known as a transient ischemic attack.
Cool.
That's
awesome.
it.
Yeah, excellent. No, well done. No, got it all over it. So obviously, they're the different types. They can also occur in different parts of the brain. We have different types. I won't go into all details, otherwise that's a whole separate podcast we could do. It's just on the brain. So obviously you have it on the left side and the right. Now, if a stroke occurs on the left side of the brain, actually the right side of the body will be affected, and then vice versa if it occurs on the right side, okay? There is another part of the brain right at the back called our cerebellum, okay? So if a stroke is involved in that region, obviously that can really impact balance, coordination, and like specific motor control. Whereas if it's more in the front part of the brain, it can affect your thinking processes, speech, and other areas as well. The brainstem is probably the worst part to have a stroke, okay, because that impacts our involuntary functions like our breathing rate, heart rate, our blood pressure, and if that's impacted, unfortunately, then you're looking at some pretty severe issues that could occur there in the hospital. So there's some different types of strokes and different locations and how they can be impacted. Now we're going to just talk about our role as a physio and an exercise physiologist in how we can help rehabilitation if everything goes okay in the hospital and trying to get them back to as best function as we can. Alrighty, so now we're going to talk about our roles, and we'll start off with Maddie. So Maddie, with a role as an exercise physiologist, I guess what's your role and how you go about treating someone who's had a stroke, whether it's in the clinic or at home? If you could just delve into that for us.
Yeah, definitely.
Cool.
So the role of the exercise physiologist right from the start is to evaluate the individual with where they were pre-accident. So what their favourite hobbies were on the weekend, their line of work, if they were quite physical, hands-on, where we need to get them back to where they were pre-accident. Because obviously you live this whole life where you're able-bodied for most of them, you'd say, and then drastically one day there's no real warning signs or whatnot when
absolutely.
a stroke is coming on. So it's out of the blue. You can't really prepare for it. So ideally when they come in, they want to get back to where they were. So we've got to find out for each individual person. No same two people walk in. It's all different. So we've got to get them back to where they were individually, workplace, leisure, activities of daily living, and independence, because you can go from being able to stand up, walk out the door, no troubles whatsoever, no support needed, no support workers, but then the next day, your whole world has changed.
Absolutely,
So you've got to pinpoint it on the head.
Yeah.
But how exercise physiology can help out with that is working out with your motor function, your tasks. So you're here now, standing up, you need so many transfers, assists and whatnot. How can we make that to be as independent and as efficient as you possibly can?
For sure.
Because post-stroke, you can create new movement patterns that aren't, we'd say ideally 100%, don't look textbook perfect. So we've got to work out where are we going wrong, where can we take you, because there is also that limit of where you can actually reach, where with your nervous system damage, this is the best that you're going to get, but we've got to get you to your best. So exercise in the gym, exercise in here, mobility, balance, strength, whatever we define your limitations to be and how we get there.
That's great. Yeah, and like before I go into my role, I guess I'll give an example. One of my patients at the moment, he had a stroke about 10 years ago, and so he was 65, he just retired, and then at about 6 months of retirement, he worked his whole life and actually moved to Australia when he was in his 30s, worked really hard his whole life, got to 65, finally retired, 6 months later had a stroke, and unfortunately, movement has, by the time I've only just started seeing him over the last year, movement's really deteriorated, can't walk anymore, can't use the left side of his body, and so it just to go back on your point, how quickly things can change and how short life really is, and it's important that we are involved so we can at least attempt to get something back so we can improve that quality under circumstances that they can't control, and which leads, I guess, a bit of my role as a physio. So obviously once everything's done hospital-wise, we actually there are physiotherapists that work in the hospital that help with that early acute stroke management, okay? So what's involved with that process usually is assessing the neurological component, so their sensation right up from the top of the spinal cord, so C1, all the way down to S2 levels, okay, which is the bottom of the spine, and also looking at strength assessments, so both sides, upper body, lower body as well, even just movement with the neck, okay, just so we can get a really understanding of where they're at, and then continually assessing that over time to see if there are going to be any changes, which are possible, but in some cases, you're not going to get that significant improvement that you would like to see, unfortunately.
All independent and individualised.
Yeah, absolutely right. So our role, I guess, is we mainly from an assessment point of view. There's a couple of tools that we use, in particular, like the MASS motor assessment scale, so that we assessing pretty much everything. So that way we can liaise with the exercise physiologist, say, hey, these are the weaknesses in particular that we really need to focus on. Can you develop a program to help build up that, or at least improve those deficits if we can? Okay,
Definitely.
so we also, do our exercise component, and we do help from a program point of view. Especially, if there's major deficits, we can identify that very well. But I guess when it comes to stroke rehab, our jobs exercise-wise are really similar, and whether it is with an EP or a physio, at the end of the day, you're still going to get that really good quality of care, and that, more importantly, the benefits that you can to at least maximise what you can achieve post-stroke in particular. So,
definitely. Well, with physios, I seem to think and come back to is more like your spasticity of your muscles. So
correct, yep.
When you don't move and you're immobilised, so post-stroke, obviously your functional capacity can be limited.
Yep.
You will stay in bed, be a bit more sedentary as per usual, and with your muscles, they are a representation of movement patterns and repetitive use. So if you're resting for long periods of time, your muscles can have the ability to shorten. And so to lengthen your arm, say you kept your arm like this, the muscle length will shorten, and then to come back out, you just won't have that capability to do it anymore. But your physios can come in and help with that relaxation or lengthening of muscle. How would you guys do that?
Yeah, no, great question, Mad. So like we do obviously a lot of hands-on work early on if range of motion is really depleted, okay, and we do see those muscle contractures or a lot of spasticity involved. So we will do passive range of movement. So trying to just extend that that movement as much as possible. We'll do hands-on work like your soft tissue massage. Some guys go down the acupuncture route. Some do your cupping. Or, either way, those are all short-term fixes. They're short-term relief and to help improve that, as research shows. However, the long-term is the exercise, and if you meld that together, research shows that can make quite a good difference with improving spasticity, improving muscle length, reducing contractures as well.
They go almost hand in hand.
Yeah, absolutely right. So yeah, we will do stuff. If, for example, if I see a patient twice a week, one of those sessions might be exercise based, the other might be hands-on based on obviously what they're coming in with. Yeah, so
definitely.
That's sort of what we go about with our hands-on stuff.
Yeah.
I guess now I think it's important to talk about important things with the brain and stroke, and how it is possible to, because I think the big misconception with stroke management is that once you have a stroke, that's it. You're not going to get any better. But it's not just us trying to sell you on research that shows that we can improve it. There is actually a physiological opponent that does occur. And it's defined as neuroplasticity. And well, Mads, you want to go into that? Do you want to talk a bit about neuroplasticity?
Of course. I was like, please give it over to me.
I knew you liked that stuff.
Back in the old days when research wasn't as great as what it is now, we're constantly developing. So you think about equipment, imaging of the brain with where things are firing off, if the brain's actually switching on and whatnot, metabolism. We weren't able to image that, say, probably 100 years ago, 50 years ago, not 100% on that figure. But in those days, they used to think the brain you were born with was the brain that it was just static. It couldn't adapt, it couldn't get better. So if you damaged something like via stroke, for example, that you were just stuck. That was it. But over the years, as research has improved imaging as well, it's been able to show that the brain can undergo reorganisation and adapting to, say, a brain lesion such as a stroke. Which is fantastic, because you don't want to get stuck with the static brain where once you have a stroke, like they used to believe, that's where you are. No, you can get better. So the best way to explain neuroplasticity is the reorganisation of the central nervous system to what has occurred. So in layman's terms, for people who have no idea what neuroplasticity means, the easiest way to probably explain it is if you've got a main road, and that's where your nervous system runs, all your neural connections, because your brain talks to itself via electrical changes and currencies and whatnot. And if there's something damaging that road, you can't go down it any further whatsoever. So without creating, say, like a back road or a slip lane or whatnot, you won't be able to get that function happening. So say that road that's blocked is causing your arm to curl or elbow flexion. If you don't use that and that road is blocked, you can't do that. So what you can do via practicing, so like a physio, exercise physiologist, is helping passively, so taking the arm, moving it through that motion, and then getting the individual to help contract is going to create those slip lanes. It's always practice. Practice, use it or lose it.
Absolutely. Yep. No, it's a really important concept to know, because, I always educate patients on that, because if they don't know that, like they often do lose a lot of hope. Like, oh, well, that's it, my brain, I have a damaged brain forever now. When reality is there is this phenomenon that does occur, and it does actually, it can make a difference in getting those benefits in repairing, motor control and improving motor control and sensation as well. So look, in terms of sensation, that can vary again. Some people, there is research that shows that it does improve, and you can get increased sensation again, and you can get other people not as much. Okay, so just to reiterate, so we're not giving out false hope out there. Like there are strokes that unfortunately it is the case that you're going to see minimal improvement. But even with that, we can still work on other areas so that you can maintain that quality of life and still do things with loved ones and things that you do care about.
Yeah, definitely.
Even if that neuroplasticity component is not quite meeting those needs that you require in order to get back to it. So
it's all individualised.
Yep, absolutely right.
That's the thing, and what you do also outside can help it. So
Yeah.
you think about your physio, your exercise physiologist. Research has shown that you get benefits, a lot more benefit if you're trying to help improve yourself than what you would if you did nothing about it.
Yep.
So you've got to be in it to win it, or you've got to be in it to get those changes.
Yep.
And you may not get any changes. That's the thing. But you're going to get no changes either way if you do nothing about it.
Exactly right. Well put. Well put.
That's okay. Thank you.
No, and I guess we can now talk about too. I know you got the active hands out. So
I do have the active hands.
Yeah. So this is something that's only come in our clinic recently, and you've been using it quite a fair bit. You did a really good PD the other day on it, which was really fascinating, especially one of our patients. So I think it's a great deal that we can bring it to the podcast and see why we use them, how you use them, and like what benefits you can from having something such as like your active hands. Yeah.
Definitely. So
walk me through it.
we'll walk you through it. So post-stroke, you can have side effects, as Locke mentioned before, such as your muscle weakness, trouble actually coordinating movements. So you've got to get certain muscle contraction and relaxation from other muscle groups to be able to grip something. So if these muscles along in the front, say front of my hand and the forearm, weren't able to squeeze adequately, then you would lose your loss of function of your hand to be able to grab, say, a cup or something like that, open a fridge door or door. So, but these muscles up here could still work of your shoulder and your arm.
Yeah.
How are you going to possibly exercise if you cannot grip something?
Absolutely.
Sure, there's ways around it, but a way that we can get exercise through the hand is actually strapping equipment to the individual to help out. So I could steal your hand.
Yeah, here we go. I'll pretend it's. I'll close. There we go.
So we'll grab the right one. That one actually might help.
Yeah,
The right one for the right one.
yeah, that's it. That's it.
Alrighty. So an example would be if Locke wanted to do a bicep curl or something like that. Let's see if we've got something. There we go. All right. We have a ball. Locke's a famous cricketer from the past, right?
Not famous. Has been. But yeah.
Here it has been. That's fun.
Yeah.
So we've got the ball in his hand, and in order to hold the ball in his hand, so he's not bowling or whatever, he just wants to hold the ball. That's going to give him a big happy high in his brain because that's cricket from his past.
Absolutely.
It's going to improve his quality of life for a brief period of time to be able to do that.
Perfect.
So what we do is slide the active hand around his hand. Now this is an average size. He's probably got bigger hands than what normally go in here.
Yep, so you can get different sizes, obviously, for different patients. Obviously, the patient that's using this has much smaller hands than I do. Yes.
So with the patient that I've used this on, she has been using it for bicep curls and in the pool as well, so hydrotherapy, lying on her back to lift her shoulders up or lift her arm up to work those shoulder muscles. So there's 100 million different uses you can do. And they're not just only for your exercise environment. I've seen online, I haven't actually tested it out, that people have been able to do their makeup holding their active hands. They put the brush in their hand and then obviously they strap it on. Someone else has had a beer in their hand, so if you're a beer lover and you drink within the right moderation, then you could drink a beer with the hand. So if Locke had no use of his grip strength, as you can see here, he's able to hold that ball in his hand.
Can't fall at all. Very nice.
Does it feel comfy?
Very comfy.
Shall I leave you like that for the day?
For the day, yeah.
Don't know if your patients would like that.
Yeah, that'd be interesting.
Can you treat one-handed?
Not at all. Not at all.
Beautiful. And just as easy to take it off.
Thank you. Very
Simple
good.
as that.
Excellent, Mads. Yeah, no, it's a fantastic tool, particularly for retraining grip. I think it's a big thing because it's such a functional thing that we do take for granted. Whether it's eating with a knife and fork, whether it's trying to pick something up, that is a very useful tool to at least get some sort of normality in a way. Obviously, it's not the same thing, but it's better than again not being able to do it at all.
Exactly.
And that's the same with any part of the rehab timeline, I guess. Whether you got no movement at all, or you can't contract. We can still work on that. We can still develop pathways and develop management strategies to help achieve that contraction or achieve that movement with exercise and with our passive work as well. So I think that's what the beauty of our jobs is, that especially with stroke rehab, is that no matter how much deficit you think there is something we can always work on so that we can always improve.
Definitely.
And so that's a great topic. And Yeah,
Wonderful.
no.
What
well
would
done.
you look at if someone did come in and they had a cerebral vascular accident, also a stroke, an initial consult?
Yep.
How would you go about it? I know everyone's going to be different, but what would you go
Again,
to?
same thing. I'm looking at functionality, so what they can do, whether it's to be more systematic, I'll look at, they call it dermatomes, but in other words, I'm looking at sensation of every single pathway from the vertebrae, okay? So I'll do like a light touch, soft touch, hot cold test as well. I'll do as well like a sharp blunt test as well, as we had another word for it, but sharp blunt's the more appropriate term. And then I'll move on to, they call it myotome testing. So in other words, strength testing. Again, same component, C1 to S2. Just looking at different grades. So we do scale it in terms of like 10 out of 10 will be full sensation, 5 out of 5 is full strength, and 0 obviously complete no sensation at all. And then 0 on the strength is they're not able to move their arm, not able to get any, or leg or whatever it is, any contraction whatsoever. So that's what we'll do to begin with. And then like look at other basic things. Again, strokes, they vary so much. Some people can achieve a sit to stand. Others, that's just not possible at all. No. And would laugh if I asked them to do that. It's
probably
just all about
offended as
well.
Yeah,
absolutely. So it's about reading the room, and that's why I do that systematic approach first, so that when I have a pretty good idea by then, when I do want to get them to do more functional tasks, such as picking up something or doing a sit to stand or walking in particular. And I'll assess whether they need mobility aids or whether they need more support during that assessment. It is very assessment based. I don't do a lot of treatment, just for time purposes really, because I really want to know what's going on, so that when the next session after that, it's all treatment from there. So and that it's effective treatment as well.
And you hit the ground running.
Yeah, absolutely. Because if you do a half, if you're not doing a proper assessment and then you just go straight into treatment, you can miss a lot of things, and then also, and it's not going to be as effective for the patient, and their timeline, their rehab process is going to be a lot longer. And for stroke rehab, it's a long thing. Yeah, you will be doing a lot of it. It goes for a long period of time, and at times you can feel like you're going absolutely nowhere with it. But again, even if you're not getting massive gains, we're still maintaining either what we have gained or what we've still got in particular. Okay, so that's why it's important that we're still doing it, because if we do nothing, things will deteriorate further, and research shows that then lifespan after that is much shorter. Okay, so
definitely, and reduce quality of life as
well.
well.
Big time.
I think one of the more important things with stroke rehabilitation is more quality of life.
Yeah.
So someone could still be happy post-stroke, not being able to walk again, but they're still able to participate in leisure activities and be with their family, friends, do their hobbies. So it's about also getting from them, what do you want out of this? Do you want to be able to work towards walking again or sitting to standing again, or is your goal to be with your family for as long as you possibly can, still able to help out, whether it's reaching and pouring your wife or your partner a cup of coffee or playing Scrabble with your kids, something like that. So us as clinicians need to be aware of what are their goals and dreams, and what are our hopes as well, and how can we work together to get the individual where they want to be.
Yeah, absolutely.
It's one of them important things. So just as Locke mentioned, doing all your objective measures and assessments, seeing how the person in front of you actually moves and their functional capacity, that is 100% extremely important, and you need to have that information for treatment plans, outcomes and whatnot.
For sure.
But just as important, it's the individual as themselves. What do they want to be able to do again? What do they want to achieve? Where do they want to go? Are they motivated at the moment? Are they struggling with anything psychologically? So we do know research can tell us that post-stroke, post-accident or anything like that, depression levels can actually go up as a result of the lifestyle change and sitting for sedentary periods of time and not being able to do what they used to be able to do. So as Locke mentioned, the objective measures and being able to see what they can do functionally and their capacity, so how far they can walk, how long they can sit on the edge of the bed for, it's extremely important. But just as important is how the individual is, so your subjective questioning. Would you like to go into how you would question someone about their lifestyle and how they are?
Oh yeah, just honestly, try and keep it pretty simple, and if they can't respond in a way due to the type of stroke that they've had, then hopefully there'll be a care or support or loved one there, and I can ask those questions with. So what they previously liked to do, what their function was in particular, are there any stairs at home, are there easy to get in and out of bed, even like what side of the bed it is, so we can work on bed mobility and transfer mobility. Honestly, very similar to you guys, to be honest. Just lifestyle factors and functional factors.
And anything else diagnoses-wise, if they've had, say, diabetes or heart conditions, because that's just as important, because that would have been affecting them prior to the accident.
Yeah, past medical history is important, and I think that comes up to pretty much our final topic, which is, obviously, like we're talking about the benefits and the positives of stroke management, and unfortunately, there are negatives to it, and the fact, it is life changing, and so we do want to prevent as many strokes as possible. And so some risk factors that unfortunately that you can't modify, that you can't change for getting a stroke is your age. So once you're over 55 years old, the risk of stroke does increase. Okay, that's just how it is. Males are also more likely than females as well. Due to the fact that obviously with increased, males are more likely to have increased blood pressure, which therefore can affect the brain, and in general as well, increased blood pressure, but that comes more into a modifiable topic, which we'll talk about in a bit. Family history, there can be a genetic component to it as well. And you could probably talk about more of this tonight with hormones, Maddie. I don't know so much about birth control stuff, so I'll put that to your hands.
Not 100, definitely, that'll come into here. With birth control, so such as if you're on the pill, the IUD, Mirena and whatnot, it can play with your hormonal, like your estrogen, your progesterone, and that can increase your risk of having a stroke with its effects on the body. But I think we'll probably jump into more your modifiable.
Yeah, absolutely. Yeah, so the modifiable is the stuff that you can control in order to decrease the risk of a stroke occurring. The big one is weight. Okay, so if you are overweight or obese, there's a significant increase in risk of strokes occurring. Other things as well, being inactive. Okay, so having a sedentary lifestyle, binge drinking as well, so drinking a lot of alcohol, smoking, illegal drug use. Increased blood pressure, which probably is affected from all the things said before as well.
Well, they all tend to come into each other. That's the thing.
Absolutely. Yep. And now that doesn't mean you never have to drink ever again, so you don't get a stroke. That just means that you do need to keep these things under control and modified, because if you do indulge into it too much, then unfortunately the risk of having stroke there's a dramatic increase in that occurring. So the important thing to do, so just to summarise, if you do see someone that is having a stroke, is to act fast, and by acting fast, break into the syllables, and Mads meaning?
So F standing for their face, is there one side of the face that's drooping? A meaning for arms, can you lift your arms up? Do you still have that neurological and functional control? S standing for speech, so can they understand what you're saying? Are they confused? You ask them what day it is, and they're like, got no idea. And then another thing is that their ability to actually speak. Are they mumbling? Can they not get anything out? And then you try and judge it overall.
And if they do fit under that category, you call 000 immediately, because time is of the essence, and then they take that from there. And then if it is a stroke, and then they are in that acute stroke management service, and then that's when we begin the rehabilitation phase, like we've outlined. And again, whilst there are some non-modifiable risks that you can't control in terms of preventing stroke, there are some that you definitely can in order to prevent that from occurring. So
get physically active, try and eat a healthy, balanced diet, reduce your alcohol intake if you are drinking over the standards. So your Healthy Australian guidelines and physical activity guidelines as well are your fantastic guidelines to look towards. So I think they say 150 minutes a week of exercise. So they recommend about 30 minutes or up to 30 minutes every few days of walking even. Your strength resistance training at least 2 days a week to help with everything in general, your weight, your cardiovascular, your heart health, your lungs as well, and strength for your muscles to keep you active and healthy.
For sure.
Along those lines. And medication-wise, medication can help manage your blood pressure, your diabetes, along the lines of that. So if you have any concerns, worries or whatnot, I'll probably recommend you to see the GP if it's anything to do with your health in that regard, to see if they can actually help reduce those factors, because there are scales and questionnaires out there that can predict. I'm not saying it's going to tell you you're definitely going to be at a high risk of having a stroke in the future or a low risk, but they can categorise you into each one of them. So you can almost get a wake-up call if you are in that high category, or if you are in the low, you've still got time to act on it.
Yep.
And if you have unfortunately experienced a stroke, you know that there are avenues and pathways that you can go down to get help, because something is better than nothing.
Absolutely, Maz. Well put. And that wraps up our podcast for today, guys. So thank you for having us. This is Maddie Law, the exercise physio. I'm Lachlan Knuth, Physio, and we're at Back to Health. And
Hope you enjoyed Behind the Plinth.
Excellent. Thanks. Cheers.